Thank you very much for joining us today for the next presentation in MSH's Quality of Care webinar series, Smart Capacity Building for Malaria, Experiences from Malawi. Through the USAID-funded Organized Network of Services for Everyone's Health, ONSE Health Activity, MSH is assisting Malawi's National Malaria Control Program to provide high-quality malaria services at the facility and community levels in 10 districts, covering nearly a third of the country. This webinar will share lessons learned on how the application of outreach training and supportive supervision, or OTSS, as part of a broader quality assurance system impacts staff performance and improves the provision and quality of malaria services. Today, we'll hear from John Munthali, Senior Technical Advisor for Malaria based in the ONSE Health Activity, and I'm serving as your moderator, Kate Wright, a Senior Technical Advisor for Maternal and Child Health based here in the U.S. First, we'll have a presentation and then we'll open it up for questions. If you have any questions during the presentation, please go ahead and post them to the chat. Okay, let's begin. If you haven't joined us before, this is the fifth in our webinar series, Quality of Care, an Essential Pillar to Achieve Universal Health Coverage for Women, Children, and Adolescents. The series explores practical experiences and lessons for improving the quality of services along the continuum of care. We look forward to highlighting and sharing lessons learned from quality of care initiatives that contribute to universal health coverage and initiating a discussion about strengthening quality of care initiatives within UHC for more effective and efficient health systems. In this webinar specifically, we'll contextualize the malaria burden in Malawi, discuss the service delivery structure, national goals and objectives around malaria control, as well as describe the USAID-funded ONSE Health Activity role in that service delivery landscape. We'll illustrate how a focus on improved quality of care and the application of the Outreach Training and Supportive Supervision, or OTSS, approach is improving service quality in Malawi. And we'll seek to understand the power of nuance in the OTSS approach and its results. Through our work at MSH, we know that delivering high-quality care relies on leaders that believe in quality improvement and healthcare workers with a certain level of clinical capacity. While essential, that clinical capacity alone is insufficient. They must also operate in an environment with the necessary infrastructure, equipment, and commodities they need to do their jobs effectively. They need the right systems in place to collect and act upon data in a timely fashion. In many countries, the private sector delivers essential services and also requires the same support. Lastly, we all must advocate for policies that advance universal health coverage, ensuring that high-quality healthcare services are accessible, patient-centered, and equitable. And now I'm going to turn it over to John in Malawi.
Thank you, Kate, for the wonderful introduction. My name is John Munthali, and I'll take you the process of OTSS, which is defined as outreach, training, and supportive supervision. In Malawi, malaria is a big burden, and it continues to affect over 30% of the population. Just to put in context, it accounts for 30% of all outpatient visits. In 2018, for example, we had over 10 million suspected cases in our public facilities, and over 6 million were confirmed malaria cases. Well, unfortunately, the underprivileged section of the society, under fives and pregnant women, have low access to preventive measures. For example, just below 65% of under 5 children and pregnant women were found to be sleeping under a mosquito net every night. OTSS is a qualitative assurance process And as ONSE, we are supporting OTSS in 10 districts out of the 29 districts in the country. And our presence is in all the health facilities in the district that we support, starting with the community level, health center level, as well as district and referral hospitals. In health centers, the services provided include primary diagnosis and care of all uncomplicated cases, but also they do provide services for severe cases. In this case, they provide peripheral treatment and refer cases to either a district or a referral hospital. At a district hospital and a referral hospital, severe cases are accorded the full treatment, but also they're able to provide routine diagnosis and case management for the entire catchment population. So in our OTSS, what we do basically is to strengthen clinical diagnosis services in facilities, but our also aim is to identify areas or needs for improvement, both in skills and in knowledge among the service providers. Our target audience includes clinicians, data clerks, lab staff, and nurses. As I've highlighted and indicated earlier on, OTSS is part of the broader quality assurance system, and it's a two-way communication process between supervisors and facility staff. And their focus is on patient-centered care. OTSS is a continuous process. It can either start with a formal training or it can start with an initial supervision. So in our case, with ONSE support, we start with a district supervision to facilities, and we do carry out checklist, and we do also observation and do data collection. So this is combined with coaching and mentorship, as well as on-the-job training with the aim of improving capacity of facility staff. So in the process of mentorship, in the process of coaching, as well as capacity building through on-the-job training, we're able also to collect both qualitative and quantitative data, and that data is collected in real time, and it's analyzed, and we're able to develop action plans. At the same time, address the weaknesses or the gaps that have been identified at that particular facility, and that work is done in partnership with the facility staff. So based on the findings, we're able to say what sort of support or what sort of activities the facility needs to do, or what sort of support the facility needs from the supervisors or from the DHMTs, which are their supervisory entity at the district level, and we agree upon who is supposed to implement that action point, and these are the action points that are followed on upon in the next rounds of supervision. As I said, it's a continuous process. Those facilities that are persistently performing well are graduated and are then subjected to in other forms of supervision, but may not necessarily have access to OTSS. But for those facilities that have got low performing, additional interventions based on their need are then identified, and the action points as well are developed and followed on a regular basis. Well, the tools that we use in OTSS, we have got a performance checklist that looks at infrastructure capacity, but also we do observations. In observation, we observe how they are doing the diagnosis, whether it's an MRDT performance, whether it's a microscopy performance, whether it's a clinical assessment, how they are assessing patients, how are they determining that this one needs a malaria test or this one doesn't need a malaria test. But we also review registers to ascertain adherence That could be adherence to test results, adherence to either negative or positive results. And as I said earlier on, based on those reviews and observations, we do develop structured mentorship programs as well as action plans that are needed to be implemented. The other tool that we use, or the other approach, is basically to review registers, these clinical or lab registers, to ensure compliance to the prescribed protocols in malaria management. This could be based on whether they comply to test results if a negative case was given a prescription of malaria, or if a positive case was treated appropriately. And those are the tools that we use. So briefly, I'll take you through some of the results from the 4 rounds of OTSS that we have supported since we started in 2018 or 2017, thereabouts. In OTSS, we track 9 indicators. As you can see, there's MRDT competency, microscopic competency, and clinical management, adherence. So there's adherence to the test results, that's negative or positive results, testing prior to treatment, and the last indicator is severe case management. In severe case management, we have got diagnosis, patient monitoring, and administration of injectable artesunate. Overall, you'll see that from round 1 up to round 4, there's been a significant improvement across all the indicators, and I think this is to do with the capacity building that we do when we visit facilities. I think we have seen a significant improvement in MRDT competency as well as microscopic competence. There are other areas that have also seen significant improvements, though not as high as the 2 that I've highlighted. So things like severe cases, that's patient monitoring. We have seen significant improvements, but we went up to 80% in round 3, then dropped to 64% in round 4. But overall, the improvements have been made in a number of indicators. Out of the 9 indicators, I would say 8 indicators have seen significant improvements in performance of given service. The first one we need to look at is MRDT provider competency in the district that we support. You'd see that in round 1, the performance was roughly around 97%, and up to now we have reached 100%. And in round 2, there was a drop to 91%, roughly because there was a big gap between first round and second round. So this also shows that if facilities are not regularly and consistently supervised, you may lose the gains that you may have achieved in between. So as you see in round 1, the performance was around 97, but because there was a gap of nearly a year due to other problems, we saw that dropping to 91%. But overall, across the district, the performance has been quite good. But if you break that one down to individual elements within the competency, there are certain things that as a project, as also we were trying to support so that they improve. I would like to give you an example of just 3 elements within the MRDT provider competence. One is collection of adequate blood, checking of expiry dates on the MRDT test kits, and putting on gloves, which is an infection prevention issue. And you'd see that we had a problem with checking of expiry of dates of the MRDT. It was just above 80% in the first round, and that dropped to around 65% in the third round. But when we intensified the supervision, that has picked up and it's just close to 100%. The other two, which is collection of adequate amount of blood and wearing of gloves, were a problem in the early rounds of OTSS, but with subsequent visits, we have seen that improvement, as you can see on the slide. The other indicator is testing prior to treatment. We are looking at how facilities are complying to these indicators. What we want to achieve is that before patients are given any form of treatment, they have to be tested. And this is part of the malaria treatment policy that all patients, before they get an ACT or any form of malaria treatment, they have to be tested. And in this graph, we are looking at the number of facilities that were compliant and that were that reached the target of 90% compliance to testing prior to treatment. In round one, we had 123 facilities, but as you see, the number improved in round three and round four. As I said earlier on, in round two, there was a gap between first round and second round. We have seen a drop by roughly 18 facilities, but subsequent supervision saw an increase from 104 to 140 up to 79 facilities. In each round of OTSS, we visit roughly 200 facilities. So you'd see that just close to 200 were compliant to testing before treatment in the fourth round of OTSS. The other important indicator that we are also tracking is severe case management. But in severe case management, for the sake of this discussion, we are going to focus on patient monitoring. This involves monitoring of patients that have been admitted and under observation in the ward. The successes that we have seen is that there is an improvement in monitoring for presence of anemia, monitoring for the presence or the occurrence of conversions, and also treatment of anemia upon discharge or once the patient is in the ward. So these were some of the challenging issues in all the preceding rounds of OTSS, and we were working on them. So we have seen significant improvements in those areas. But what is still more challenging, as you see, is that facilities are not able to check vital signs every 4 hours as demanded by the SOPs in management of severe cases, and also observation of glucose levels every 4 hours, and also scheduling for appointments, follow-up appointments with patients. But as you would see, the first two bullets that talks about the challenges, these also lead us to availability of resources for the facility to check blood pressure, to check temperature. They need maybe blood pressure machines or thermometers. So some of the facilities do not have adequate resources. Equally, blood glucose levels, do they have glucometers? Very few facilities would have that. Well, this supervision does not necessarily take into account that. I think it does look at whether that activity is taking place or not. So you'd see that performance is improving in areas where basically it doesn't require resources, but where there are resource issues, performance is somehow affected in facilities where they do not have the resources. So what lessons have we learned from OTSS? We have implemented OTSS for a number of years now, and we have learned a number of lessons. one of the most important lessons that we have learned is that OTSS is a powerful way to tailor technical assistance based on data-driven approaches in identifying gaps and weaknesses at each individual health facility. Out of that, we have been able also to provide targeted support, targeted intervention, and even targeted capacity building activities based on the gaps and weaknesses that have been identified. Instead of just having bracket interventions, OTSS is able to identify what sort of need or what sort of capacity building activities each facility may need or may require based on the findings of OTSS. So because of that, if you implement OTSS, you're able to actually identify what sort of support each facility may require or each facility needs at a specific time. The other lesson that we have learned is that OTSS is an expensive exercise, especially when you are implementing it from a centralized position. Because it requires you to have supervisors drawn from different places, so you need to cut for their transport, accommodation, and the like. But moving forward, when you've got maybe a decentralized approach, I think the cost may significantly go down. So in institutions in countries where they would want to continue implementing OTSS, I think they may need to look at decentralizing the whole process, because implementing it from a centralized position, it has got significant cost associated. The other lesson that we would like to highlight is that OTSS is a vertical strategy. And how does the application of that limit the improvements in the entire system? So the focus of OTSS has been purely on malaria supervision. It does not necessarily integrate with other supervision. So the focus has been purely on case management, so diagnosis and treatment of malaria cases. Where in severe cases, it does look at other issues like whether patient monitoring is in accordance to the prescribed treatments or the described management of those severe cases, and that includes maybe checking of anemia, checking of vital signs, checking of other important issues in a patient, but that necessarily does not cut across another conditions. So being a vertical program, it has got its own limitations as how it impacts on other conditions and how it affects or impacts on the entire health system. So this is something that maybe as countries or as maybe different programs or maybe different stakeholders would like to adopt, they may need to have discussions with other stakeholders from other technical areas how best to utilize OTSS as they move forward. Well, where does OTSS improve quality of care? I think we have talked a lot about how OTSS provides support to health workers. In short, I would say OTSS does ensure that health workers are adequately supported in acquisition of skills, in also impacting knowledge about management of malaria, both uncomplicated and severe malaria. There's a huge element of strengthening the skills of health workers in OTSS because supervisors are able to provide on-the-job training, they're able to do coaching and even mentorship of all supervised health workers that they encounter during OTSS. The other area that OTSS does contribute to in the improvement of quality of care is it support informed quality improvement. It's based on evidence. The supervision is based on the current practice, the current acceptable protocols or current acceptable policies that countries have adopted. Now, the most important question that we've always had and that we always ask is scaling up and sustainability. In our country, OTSS was primarily supported by PMY through a Malaria Care program, and now ONSE took over from Malaria Care when Malaria Care closed down, and we're still continuing it. And we also know that Global Fund is also supporting OTSS in the districts where we are not supporting, and we are also aware that MSH is implementing OTSS in Benin and Nigeria with support from USAID and Global Fund. We are also aware that Global Fund is also supporting OTSS in a number of countries. Well, if looking at that, you'd see that OTSS primarily is being supported by donor agents, PMY and Global Fund. But it's important that countries take it on board and start supporting it as one of the core activity in the management and treatment of malaria. Fortunately, in Malawi, OTSS has been incorporated in the National Malaria Strategic Plan as one of the core activities that has to be implemented. So the current strategic plan runs from 2017 to 2022. So we see that we are in the right direction in trying to bring in sustainability. So when the government puts that in the strategic plan, I think the next step is for the program, that's the National Malaria Control Program, to look into ways and means of how to sustain and support it's this important activity. I think governments should look beyond the donor support and try to come in and support this important activity. Thank you.
Thank you so much, John. In a moment, we'll begin responding to your questions. Please type them into the chat box below. While we queue up the first questions, I invite you to continue the conversation with us after the webinar. You can reach John and I through the email shown on your screen. And as a reminder, you can find the recording of this webinar and all of our webinars in this series on our YouTube channel and on msh.org. Okay, I see that John has unmuted, so I'm going to go ahead and ask our first question. And John, this question is directed at you. What have we been hearing from participants going through the OTSS process? What is their feedback been about the process, and what are some of the things that they have taken away from the experience?
Oh, okay, thank you so much. Well, so many facilities have attested to the benefits that come with OTSS, more especially the element of on-the-job training. I would give example of MRDT performance. We do not have a specific cadre that does the MRDT testing. And in most facility, they would use available people on a particular day. So when we do OTSS, we actually provide the training right there and then, because most of the cadres that are used may not necessarily be qualified for a formal training. So every time we move around, we find people that are in need of on-the-job training. It could be in MRDT, as I've said, but also there could be people that maybe they may need on-the-job training with microscopy, because at times you may find that some may not have had a chance to look at severe cases. So when we we move around during OTSS, we're able to provide that kind of training. And it also cuts across in other areas such as patient monitoring in severe cases, but also administration of injectable artesunate. As you know, injectable artesunate administration is a little bit complicated, but we're able to provide that. And that gives, that provides capacity building at the facility level. Thank you.
Thanks so much, John.
Thank you.
For the next question we have, there's a question about what is the timing between the rounds of OTSS, and is it the same facilities that you're using OTSS in for each round?
Well, timing, ideally we are supposed to visit facilities every quarter. So roughly every 3 months, ideally we're supposed to visit those facilities. But in certain circumstances, depending on availability of resources, we have been able maybe to visit those facilities maybe every 6 months. I think, as I said in the presentation, that facilities that have had maybe 3 or 4 visits and they have been performing quite well, we normally graduate those. As you know, our country has over 700 public facilities, and we try to make sure that we visit each and every facility. So those that are performing well, we graduate them from OTSS, but they are supported with just the routine supervision that the DHMTs provide. Thank you.
Thanks, John. Another question that's more clinical in nature. What is the national policy on clinical diagnosis? For example, if there are stockouts of RDTs and there is no microscopy available, can providers still treat? If so, how was that factored into the analysis?
The policy always is that test and treat. And that's for uncomplicated cases. We expect facilities to basically make sure that every uncomplicated case that works in a facility is accorded an MRDT test. But we know circumstances arise, but before that, in severe cases, there is always that room that they can provide peripheral treatment and refer. Then the next level would confirm if it's indeed a severe case. But in circumstances where MRDTs are not available, well, I think facilities have used judgment to make sure that they use the clinical diagnosis, though we do not advocate for that, but that is inevitable in circumstances where stockouts are there. But we are glad that PMI and the Global Fund have always sustained availability of MRDTs on a regular basis. But where we do not have MRDTs, I think facilities have used presumptive treatments. And well, the OTSS also looks into account when we are doing OTSS, we do actually review availability of commodities, and MRDTs are one of them. And we basically find out the number of days they were stocked out, and that takes into account of that in the analysis. I think the system we use the EDS, which has a DHS2 element. I think takes that into account during analysis. Thank you.
Terrific. Okay, and we have another question more related to programmatic side. Has there been costing data collected to allow the government to implement it, OTSS without donor funding?
Yes, the preceding mechanism that was supported by PMI, that was what was called Malaria Care. that's when the OTSS was being introduced, but then they did a very study to look at cost implications for implementation of OTSS. I think they had surveyed a number of countries like Ghana, Kenya, Malawi, Mali, Mozambique, Tanzania, and Zambia. I think on average, the cost on a daily cost, I think per visit was quantified in dollars, but there were a number of factors that were looked into. But for instance, I think the cost per day per visit was around $180 in Ghana. But for instance, in our country, if you're looking at 2 supervisors, that's per 2 supervisors. In our country, it was $125 per visit per day, just for those 2 supervisors. So as I said, it's a slightly expensive undertaking. In a typical round of OTSS, we have 24 supervisors in our country. So if you look at those, then per day you're talking of close to $1,000 or $1,000 or so. So for 12 days, that these are just direct costs. Indirect costs are not even factored in here.
Thank you so much.
And that study was published by. Sure.
Oh, go ahead. The study was published by.
No, was published by Malaria Care.
Great, terrific. Thanks so much.
Thank you.
Another question we have is, what is making the more challenging items for severe malaria cases challenging? Do we have gaps in supplies, or are there issues more related to specific behavior change?
Well, there are a number of issues as regards to severe case management. One is severe case management is managed at the second level of health facility, which is a district hospital. And if you have a case maybe at the community level or maybe at the health center level, what they provide is only peripheral treatment. Now, then they are referred. So the referral at times, then the patients have to travel on their own to the facility where they've been referred to. It could be maybe 10, 20 kilometers away or even more. So at times, patients may not be able to get to a facility, and in that circumstance, you find that the condition worsens. Now, if they manage to get to a facility, well, it's also the issue of availability of working microscopes, because they have to confirm that is indeed a severe case. Now, if microscopes are not working and they cannot confirm, then this patient is presumptively treated. So they are not sure whether it's indeed a severe case or it's indeed, if it's not, or if something else. Well, even if when the case has been confirmed and they are placed in a ward for admission, there are so many issues that have to be done. As I said, there's patient monitoring is a big element, so resources would also hamper in terms of monitoring glucose levels, monitoring of vital signs. Those things would also affect that. But also, when the wards have been overstretched with so many patients, well, then the staff are actually overstretched and are not able maybe to provide the required care that those patients are supposed to receive. Sure, those are some of the limiting or the challenging issues that we do find out when we're doing this OTSS.
Terrific, great. Okay, we have time for a few more questions. Here's one about the provider and facility experience. What have you heard from the facilities and providers themselves about their experience with OTSS, and has it been encouraging to the program?
Well, to the National Malaria Control Program, I think as a program, they have included OTSS in their national strategic plan as one of the core activities that has to be implemented by the government based on the results from the previous so many rounds of OTSS that were done. They have seen that it's beneficial. It actually improves performance of facilities if done in the correct manner. If every quarter facilities are visited, then they provide on-the-job training, coaching, and mentorship. You see significant improvements in performance of those particular facilities. But also OTSS accords the only opportunity for facilities to be visited, to be supervised, to be provided with technical assistance. And facilities do appreciate, when we had a break between round one and round two, the time we were going to round two, facilities were complaining that it has taken a long time without them being supervised or visited, and the facility in charge were more especially complaining towards the people that were doing MRDT have never had maybe that supervision or on the job capacity building activities. So OTSS is something that both facilities, even the program, that's the National Malaria Control Program, do need and do require, and they do testify that it's an activity that when it's well implemented and well funded, it does change performance of facilities as far as malaria case management is concerned. Thank you.
Terrific. Thanks so much. I wonder if we can go over to our colleague, Tom Hall. Is it possible for Tom to connect and answer the question around a recommendation, whether or not it's recommended to integrate other services into OTSS so it's not a vertical program? And what other areas can we help improve capacity building using OTSS?
Thanks. So yes, OTSS is being used by MSH in other countries to under an integrated platform. So while OTSS was originally developed using funds from the President's Malaria Initiative to improve malaria services delivered in health facilities, in particular malaria case management and delivery of malaria and pregnancy services at ANC. It was also observed that once the tool was well developed and performance was observed to improve, that with the support from ministries of health, other other health services provided at health facilities could also benefit from the platform in an integrated manner. So in countries such as Nigeria and Benin, the ministries of health have also agreed to adapt to the tool and provide the checklist for observing and the performance of health workers providing other services beyond malaria, such as related to maternal and child health. So it is possible to have an integrated platform that would be benefit from the OTSS tool. So in that case, obviously, the details of that were being observed and effort to improve under malaria now would be reduced so that the time would be allowed for supervisors to go to health facilities and to observe the range of services provided by the health workers, particularly at small facilities where you have one or two health workers who are providing all services. And so it has been integrated in other instances. And so I think that is where obviously the benefit of this tool comes from.
Terrific. And I wonder if John has anything to add from the Malawi experience.
Well, I think, as I said in the presentation, when I was focusing on severe case, I think, the challenges that we have been observing, if we had an integrated approach, those challenges could be minimized. I think OTSS, as Thomas said, is a very important platform. It's a powerful tool. Maybe like reproductive people, maternal and child health people, the National Malaria Control Program could come together, agree that, okay, let's have an integrated approach, more like OTSS, whether they want it to be modified. But if the approach is the way we do in OTSS, I think these other programs, these other technical areas can benefit a lot, because it does provide real-time data analysis, and you're able to develop action points, action plans for a specific facility that you have visited. Thank you.
Great. Okay, one more question, one final question to John. Is OTSS available to anyone, and how can others access it?
Yes, OTSS is available to anyone, provided they are provided with login credentials. So, for example, in Malawi, we provide login credentials to all government employees or facility in charges. It's the same way you log in into DHIS2, but this is an EDS DHIS2 instance, and the features are similar to DHIS2, and the way you analyze data is like in DHIS2. So for our country, all our counterparts in the Ministry of Health are provided with the credentials. So because this OTSS was being done in many countries, previously there was one instance. So if you log in, you could see data for other countries. But I think then countries, when they became, when their capacity was deemed to be optimal, they have broken away, so they've established their own country-specific instances. So I know in the countries where OTSS is available, access to data for every facility is open to those that have got login credentials.
Terrific. Well, thank you everyone for joining. I want to thank the ONSE project and John Munthali again for his expertise in this area and for presenting to us all on the results of the OTSS in Malawi. Thank you to Tom Hall again for his participation in answering the questions. And we appreciate your participation as participants today. We will be sharing the slides and the recording of this webinar broadly, and we'll send out notices to everyone in regard to how to access those.